Family Medicine and Primary Healthcare Micromodules 2016 by Professor Carmen Wong. Common Skin Conditions by Professor Carmen Wong. By the end of this micromodule, you should be able to describe a rash and know how to diagnose and treat the following conditions: atopic dermatitis, contact dermatitis, plaque psoriasis, tinea, urticaria, and acne vulgaris. So in history taking, for skin conditions, you may have a look at the history of presenting complaints. Okay, so things like where did the lesions appear and when? How has it changed? Is there any associated symptoms? Any recent events or exposure? Thinking about the general medical history, think about any chronic medical problems or recent illness that might suggest a systemic cause. You may look at the history of allergies, any allergic reactions to medications, foods, topical agents, any history of hay fever or asthma. Also, what's the medication history like? What are they taking systemically, topically, from prescription medication, over-the-counter medication? How long for? Any medication that's taken much more recently that may attribute to their recent kind of rash. Any family history with skin conditions as well. So when you're examining the rash, try and note the distribution, the position, the shape, size, color, the consistency, any deeper kind of structures that it may be affecting, and where does it extend to? Is it attached? Is it to the skin, to the periosteum, to the bone? Are there any other signs? Is it warm, pulsatile? Are there any bruits? Does it transilluminate? Any other special examination techniques? Now, this is a handy picture to describe some of the rashes. And get used to these terminologies because this is what we're expecting you to describe the rash when you're in clinic as well, or if you see a picture of a rash. So if you're talking about a flat rash, that is, even if you put your hand on it, you can't feel any bump, you won't be able to feel the rash at all. You're talking, it's going to be a macule if it's less than 2 centimeters, and a patch if it's greater than 2 centimeters. Things that are slightly raised, okay, so it'll be a papule if it's less than 1 centimeter, and a plaque if it's more than 1 centimeter. And the plaque usually is used for a much more extensive area. Nodules tend to be much more spherical, and they extend below the surface. And a wheal is a papule or a plaque that's formed by edema of the skin. Then you can have fluid-filled lesions. These may be vesicles. Now, vesicles tend to be less than 1 centimeter and usually clear serous fluid, although sometimes there might be blood. Bulla is the same as a vesicle, but larger than 1 centimeter in size. Now, a cyst is slightly more semi-solid. Pustule is different because it has more purulent fluid, and depending on the size, they can be called furuncles, carbuncles, abscesses. You may also have some depressed lesions, such as a fissure, which is a linear erosion or ulcer. The erosion is just on the surface, so it's very superficial, whereas ulcer, you're talking about, and an ulcer is where the skin loss extends below the epidermis. This is a chart to show different etiological categories of rashes. So they could be inflammatory in origin, so talking about allergic or contact dermatitis, atopic dermatitis, etc. There are also viral, bacterial, fungal, autoimmune causes, and some that don't fit any of the categories above, such as scabies infestation. So atopic dermatitis is when you have this chronic relapsing IgE-mediated inflammatory skin condition. It's very common, so you would come across this previously. It's seen mostly in infants and children. And what you get is itching and erythematous patches and plaques. Now, those plaques could have lichenification, excoriation scales, and crusting with dry, itchy skin, and that shows it's much more of a chronic kind of cause. Areas as typical include the flexor surfaces, antecubical, popliteal foci, the face, and around the neck. And because of its itchiness, is exacerbated really by the constant scratching and rubbing that occurs. In infants, the distribution is a little bit different. It's around the cheeks, the chin, the scalp, and extensive surfaces. Now, often there's a personal or family history of hay fever, asthma, allergic rhinitis, or food allergies, or allergic conjunctivitis, etc. It's important to ask about the effect on quality of life and also psychosocial well-being, because rashes tend to have a greater impact on quality of life than what we actually see. So the management of atopic dermatitis, the mainstay is to prevent it from happening, particularly if it's recurrent, to avoid allergens. So avoiding possible triggers or irritants, such as clothing or a change in soap detergents, or disinfectants, etc. There may be other triggers that may be dietary in nature, such as cow's milk, eggs, peanuts, wheat, fish, or shellfish. Some may have inhalant allergies, so this might be house dust mites, cockroach, pollen, or molds. Things like a change of climate, extreme climates may trigger that, so sort of the extreme colds, or even in hot, humid kind of weather, stress, and also lack of sleep may exacerbate atopic dermatitis episodes. So the mainstay of management is to use emollients or moisturizers, and really using that, applying that soon after bathing, because bathing could dry the skin, particularly if the water is really hot. For areas in which there's a flare-up, that it's red and inflamed, so that you may use a 3-day course of steroids. 3-day courses have been shown to be as effective as 7-day mild courses, as long as the steroid is of the right potency. So it should. So rather than giving a mild steroid for a long period of time, it's probably better to step up so that they have a shorter period of steroid contact. You may consider tacrolimus as a second-line therapy, and the current recommendations is not to recommend any dietary exclusions or antimicrobial interventions for most patients, so no antibiotics are needed, unless it's obviously infective in nature. Contact dermatitis. Now, you may have acute dermatitis, so you may see vesicles or bullae, and there's prominent erythema, and it's usually in contact with an allergen. So there's usually a very distinct distribution. The area is really itchy, could be weeping, and there could be exudating kind of fluids with crusting. So what makes you think that it could be contact dermatitis? Usually the edge is very pronounced, okay? So it's well marked, and then that you can start investigating into the different causes of the contact dermatitis. Now, with chronic contact dermatitis, this usually comes with erythema, scaling, and the itching, but not particularly with vesicles. So management of contact dermatitis. Now, it's important to delineate whether it might be, whether you think it's a mainly irritative contact dermatitis or an allergic contact dermatitis. So the mainstay is to identify and avoid precipitating allergen or irritant. So for rash and symptoms, actually for both, you use topical corticosteroids, particularly for mild to moderate or localized allergic contact dermatitis. Irritant contact dermatitis, however, steroids tend to be less effective. Now, you may consider systemic or oral steroids, particularly if the rash is more severe or widespread, involving the face or mucous membranes. Although you're using steroids, also remember to provide them some lipid-rich moisturizer to decrease irritation and to improve skin barrier function. So nappy rash is often an irritant. Contact dermatitis is well demarcated. There may be some elements also, if it's particularly for a long period of time, there might be some allergic elements to that as well. So the mainstay of that is actually using a barrier cream after cleaning, and that actually helps healing. If there is an allergic component, then steroids might be effective as well. Other things for contact dermatitis, cool compresses, oatmeal baths can also reduce symptoms of dry rashes. Urticarial rashes, also known as hives, are wheals that they can occur anywhere. They're also very itchy. They typically come and go, and they last for less than 24 hours. There may be continuous episodes of lasting up to about 6 weeks. It could be an episodic kind of pattern, or you may have chronic pattern of urticaria that lasts more than 6 weeks. So these may be idiopathic, an allergic manifestation from things like medication, infection, heat, cold, pressure, exercise, contact with various substances, or autoimmune response. Be also careful to note whether there's any angioedema that may be involved, particularly around the mouth and the bowel, as this occurs in about 40% of patients with urticaria. So management of urticaria, well, initially you need to think about whether this might be an early sign of anaphylaxis. So check your ABC and consider immediate treatment with epinephrine if you're thinking that it could be. So look out for angioedema. Next, you may think about, for those more intermediate kind of causes, to see whether or not elimination of causative allergens could also improve symptoms. This may be things that they've eaten or perhaps medication that they're allergic to. In chronic urticaria, that of longer than 6 weeks, you're really trying to identify and eliminate the cause, okay? So this could be any drug, any physical stimulus, any infection or foods, and really try and control the symptoms as much as possible without medication. Medication-wise, for chronic urticaria and for acute urticaria, you should prescribe second generation antihistamine to be taken orally. So this could be cetirizine, fexofenadine, loratadine. Now, if the symptoms persist for a few days for acute urticaria, or for longer than 2 weeks for chronic urticaria, you need to increase the dose of your second generation antihistamine up to 4-fold if they don't have any adverse effects from this. So with the evidence, although you may see a difference in practice, is that they tend to recommend this more than using the sedating H1 antihistamines. For chronic urticaria, if symptoms are persisting 1 to 4 weeks after updosing, third-line options include various things such as omalizumab, cyclosporin, or oral corticosteroids. So tinea. Tinea is a superficial fungal infection or ringworm. It starts off as a small patch, but they enlarge, and they're very well demarcated annular lesions, so they're round. Tend to be quite scaly around the edges and red, and the central area is usually a little bit clearer. They're intensely itchy, so you may have a different nomenclature according to different distribution of the rash. And the most common dermatophyte is trichophyton, microsporum, and epidermophyton. So treatment of tinea is fairly straightforward. You advise the patient to keep the affected area dry. Usually moist, warm areas tend to increase the growth of tinea. So topical antifungals are usually sufficient. So the patients are asked to apply to the lesion and 2 centimeters surrounding the lesions, and usually it disappears, depending on the size of the lesion, within a couple of weeks. Larger lesions may require a 4 to 6 week treatment. So creams you could use include terbinafine, you could use clotrimazole, and also meconazole. Meconazole is also available in different formats, such as aerosol powder or lotions, so different preparations. If these fail, then you may consider oral antifungals, such as terbinafine, if infection is extensive. Acne vulgaris. So acne occurs primarily on the face, but is also seen on the upper trunk and back. So you may have open comedones, closed comedones, pustules, erythematous papules, and erythematous nodules. Okay, so comedones actually develop when there's excess sebum production due to androgen access, which blocks the hair follicles, and it's due to the proliferation of Propionibacterium acnes on the skin, which contributes to the inflammatory lesions. Treatment of acne vulgaris. So many patients may perhaps think that this is due to poor hygiene, but actually that's not true, and it's good to dispel that misconception. The improvement can take up to 1 or 2 months following treatment, and some patients may have also skin irritation from their treatments as well. So first-line therapy with mild acne, so you can try some topical retinoids, particularly if they have comedonal acne, or topical benzoyl peroxide. Or you could provide combination therapy, particularly if the patient has mixed inflammatory and non-inflammatory lesions. So you can use benzoyl peroxide with topical retinoids, or benzoyl peroxide with topical clindamycin. In some cases, you may want to offer triple topical therapy. For moderate acne and acne unresponsive to topical treatment, you may want to add oral antibiotic, such as doxycycline, to the above. For severe acne and acne resistant to 3 months of oral antibiotic plus topical therapy, for women, there's actually the oral contraceptive pill or oral spironolactone that could help. And for both men and women, you may consider starting isotretinoin. Psoriasis. Psoriasis is a common inflammatory multi-system disease that predominantly affects the skin and the joints. It can be triggered and exacerbated by certain drugs, infections, skin trauma, obesity, stress, and other environmental factors. So you have these really thick, small to very large plaques, which are pink, red, with silvery white scales. Typical locations for psoriasis are elbows, knees, and lower back, and plaques are usually quite intensely itchy. There's a bimodal onset, so at a younger age of 16 to 22 years of age and 57 to 60 years of age, although the majority of cases actually occur before the age of 45. So psoriatic arthritis may occur in a quarter of the patients, and particularly affecting the hand and the foot joints. Patients with psoriasis have been known to be at a higher risk of cardiovascular disease, stroke, depression, Crohn's disease, and ulcerative colitis. So in the treatment of psoriasis, consider patients' preferences and ability to adhere to treatment. So there's a few topical treatments. Emollients, definitely. You should advise all patients to try and really restore the protective barrier that they have there. Corticosteroids, such as clobetasol, is used as first-line treatment. Other things such as vitamin analogs, such as Dovanex, as well as things like tazarotene, dithronol and coal tar, and all these could be used in combination. If topical medication fails, then the patient will need to be referred for phototherapy, where they can have UVB radiation, laser therapy, and PUVA therapy. So some practical tips and summary really is to really try and describe as many rashes as you can see, because the more practice that you have, the more automatic it will become. Think about patients' psychosocial history and their impact on their daily activities and their lifestyle and their behavior. So they might actually be having some behavior that might be aggravating the condition as well. Formulate some differential diagnoses to your rash and management. You will find that actually sometimes doctors will go back to the history to try and find a different diagnosis, particularly if the rash isn't improving. You may also want to compare your presentations of what you see in clinic with other photos or cases that's available on the internet for comparison. You will be given some in-class scenarios where you will be asked to describe the rash. This is really just so that you can practice seeing different sort of rashes and also knowing what may be some of the intricacies in managing kind of skin rashes and what might be sort of similar kind of rashes that you see and the differentials that you may have as well. You'll certainly see some rashes in clinic, and we will be expecting you to take a history to examine, to formulate your diagnoses of these presenting cases as well. Good luck, and I wish you well when you're assessing skin conditions in our clinics.